I'm going to start first with, this notion of fixing comminuted fractures is we've really highlighted some of the tips and tricks and techniques, but I'd like to kind of ask the panel really where in the femur assessing alignment and articular surface reduction is fairly straightforward, but how do we assess length, Christian?
Very important part for the judgment is fibula. So usually fibula is fractured, and if you have a gap in the fibula, you can see it. You can also use your contralateral side. You flex underneath the towels your contralateral side and have an idea and compare it with the ipsilateral side. So fibula radiographically and entire lower leg clinically.
Okay, so we have the fibula, we have some cues on that. We have on the femur side, are you scrubbing out, are preparing the articulars or the length of the femur on the other side? How do you assess the comminution and the potential shortening on the femur side?
If I have comminution, I do preoperative measurements with the meter stick, top of the femoral head to the distal lateral condyle, and note it and have a reference.
Great, thanks. Utku, with your traveling traction, kind of what are your recommendations for that? Do you have a full striker setup or your external fixator set, or do you have a minimal set that you can use multiple times? The only thing being non-reusable is the pins.
Yeah, of course, you don't want to use an external fixator, which is much more expensive than probably any other implant we use, the total cost. What I think what you can do, you can have basically this reusable parts, the bars and the clamps. I usually have them put in my nailing set, is inside the set, so you don't need a separate set to build it up. The only thing that you need to you may need to use every case is the 2 transfixion pins. Basically, the new cost every case is just the transfixion pins. You should not use a brand new X-Fix frame every case.
Yeah, it gets pretty expensive, and it's certainly important to understand that. So thanks for that. And then David, if you could just talk a little bit about, I think you did a great job simplifying your approach to the incisions. Tell me about timing. How do you decide when to fix these?
Yeah, that's a good point. I didn't really get into staging, but that's, I think critical. I'm about to talk about the pilon, where it's another place where the soft tissue envelope's not very friendly. So particularly in cases where you're planning dual approaches, if there's a lot of swelling, you can, do a provisional external fixator, wait for swelling to come down, and then do your definitive surgery later. I don't think it's as mandatory maybe as in the pilon. Like in pilons, I would say it's like almost 99% I'm staging, whereas in plateaus, sometimes if they're not too high energy, you can do the surgery in a single stage. But certainly if there's any concerns about the soft tissue envelope not being ready, but the fracture needs 2 approaches, just stage it with an X-Fix.
Thanks. Okay, any other questions? Yes.
You showed the case with the migration and subsidizing on the medial side in the drug abuser. What's the reason? Is it a failure of the locking plate connection, or is it migrating in the bone, the screws?
I think it's just I think the plate's just slightly bending. Like it's just such a big...
The plate is bending.
Yeah, I think it's just a slight cantilever of the plate that's like slowly bending, because the screws are like 5'5". There's like 7 5'5" screws all up into the medial plateau, so I don't think there's any migration of those or movement of those. I think it's just when you're spanning a really long comminuted metaphyseal segment, there's just the slightest cantilever bend in that plate. But that translates to maybe 5 degrees of varus, which we all know is pretty detrimental.
Yeah, it's just a complete the other side has no longitudinal stability, so good. Well, thank you.